Yeah, good morning all. Welcome to the session on aesthetics and ptosis. The session would be chaired by Dr. Betharia sir. Co-chairperson is Dr. A.K. Grover sir. As convener, we have Dr. Akshay Nair and co-convener is Dr. Milind Naik. So without much ado, I would request the chairpersons to start the proceedings. Betharia sir is there? Or Grover sir, you can start.
Morning, everyone. We have an excellent session lined up, and we are grateful to the BOA for having given us the opportunity to organize this session. We have all the aspects of aesthetics and of functional surgery lined up, but particular emphasis is on aesthetics, ptosis, and some grafts. I welcome you all on behalf of all the chairpersons and co-conveners. And we also have Dr. Betharia, who's joined us now. And I'll request him to say a few words before we hand you over for the start of the session. Dr. Betharia, please, Chairman. Dr. Betharia, can you unmute yourself, please?
Am I audible now?
Yes, sir. Now you are audible.
Good morning, everybody, and thank you, Dr. Ashok. I think without wasting time, let us start the session. And I request the convener to start conveying the session, please.
So, Dr. Akshay Nair, sir, and with the permission of the chair, we will start the session. The first speaker is Dr. Debraj Shom, sir. Sir has started sharing the screen. His talk is on rejuvenation techniques for the under eye areas. And we all know he is one of us who does a very facial cosmetic work in the Mumbai and is world renowned for the same. Over to you, Debraj Shom, sir.
Thank you so much, Sumit, for inviting me here. And thank you so much to the entire BOA, my teacher, Dr. Lahane, Dr. Ragini Madam, Dr. Preetham, Swapnesh, and all the other members of the BOA. Thank you so much for having me here. It's good to see friends in this pandemic out here. My name is Debraj Shom, and I will be speaking on under eye issues today and combination therapies for the same. There are some financial disclosures which are in place. I am a Asia Pacific key opinion leader for Allergan, MERS, and Aptos for approximately the past decade. And obviously, acknowledgements need to be given to the aesthetic clinics, the remaining consultants in the aesthetic clinics. We are 8 consultants at this moment. I always say that the eyes say it all, socially and otherwise. When people look at each other, they look into the eyes. And when you look into the eyes, it really conveys age. Whether it is a top Bollywood superstar or it is any one of us, aging spares no one. And because the under eye area is an area which has the thinnest skin of the human body, the rest of the face might look taut and might look young, but it's the under eye area which really starts to convey age. And we all know that the OG curve is something which is a sign of beauty in males and females, but is more easily demonstrable in females. And this is best seen when the female is looking at 45 degrees. It's basically a concavity below the under eye area, followed by a convexity of the malar area, followed by another concavity, and then the convexity of the mandible. So essentially, this is a sign of youth. And essentially what aging is that everything is sagging downwards and medially. And if everything is sagging downwards and medially, the under eye tissues are slowly and steadily shifting downwards, leading to the nasolabial folds becoming more prominent as we age and under eye hollows developing as we go ahead and age as well. The symmetry of the eyes are extremely critically important. When you look at this beautiful model, you possibly have not even noticed that there is an asymmetry in the lip. And if you look carefully now that I have brought it to your notice, you will go ahead and see that the right side of the lip and the left side of the lip are very different from each other. And you did not notice this because the eyes are perfect mirror images of each other. So oculofacial plastic surgeons all over the world play a critical role in aesthetics, because if you can operate on the eyes, you can operate on the brow, and you can operate on all the surrounding areas, it does make for a very, very aesthetic face. And it is something which can really transform faces in that sense. Now, as I said, the under eye areas show the earliest signs of ill health. Depending on whom you're speaking to, dermatologists may feel that fillers will be a panacea which will solve everything. Plastic surgeons believe that blepharoplasty is a similar thing. But actually, the truth is that you will go ahead and require all sorts of treatments, all different types of treatments in order to treat people. When you look at this particular patient, the question that usually arises is do we treat it medically, do we treat it surgically, or do we treat it both? And generally, under eye areas occur along a continuum. What that means is that basically what someone will treat with surgery, others will treat with laser and fillers. And actually having both tools in your armamentarium are very critical. And that's where I think the role of oculofacial plastic surgeons really amplifies. Now, obviously, even if you did perform a surgery in this particular patient, the texture, the tone, the blemishes, the scars, and the quality of the skin will not be addressed with surgery alone, which is why a lot of people are dissatisfied despite undergoing surgery. And that's something I think is very critical to add into our skills and armamentarium. Now, we over the years have developed this nomenclature which is related to landscaping. In my opinion, teaching has to be all about simplifying things. And if we can describe things according to nomenclature, which everyone understands, then it becomes easy to teach our juniors as well as demonstrate to our colleagues results for each condition. Now, for instance, if we call them troughs, tunnels, valleys, and mountains, each one of us knows what that means on on land, and therefore it becomes easy to demonstrate it on the face. When we talk about troughs, we mean the theater of deformity. When we talk about tunnels, we talk about the hypertrophic orbicularis oculi. Valleys and mountains are something that we are aware of as well. And comparing this with landscaping allows us to understand the problems. For instance, it's very important to understand the type of people that we are dealing with. Now, when this sort of a patient comes in, we understand that the theater of deformity in this 28-year-old is being caused by the reasons that I described earlier. The hollowness is going to worsen as they age. And as the hollowness worsens, the theater of deformity is going to look worse. Of course, we can also see that there is a small mountain above the valley. But that mountain is more a relic of the way volume has disappeared out here. And therefore, treating this with fillers is the way to go forward. And the moment you treat it with fillers, you can see the lid cheek junction has actually shortened, which is the lower lid appears fuller. It appears much more youthful. And that is what we are trying to create in that sense. Similar for this patient as well. Young patient, really surgery, there's no role to play. And if you know how to use your Hyalocross or your Y-Cross fillers, you'll be able to go ahead and treat these patients very easily. 15-minute procedure, they are out, they are happy. The results typically last about 18 months or so. And who says surgery lasts a lifetime? So therefore, in these sort of patients, when we see patients being treated with fat restoration or fat surgery, we think it's an overkill because fat surgery involves a surgery where you're removing fat from different parts of the body, and fat can be very unpredictable in the sense that it can disappear, it can form lumps, and you need to remove it. So in today's day and age, with the predictability and the longevity of the fillers, I think that it's not justified. The return on investment is not justified in performing surgery in these patients. Now, this is a slide from one of my closest friends, Dr. Milind, and this is someone that everyone from LV Prasad will recognize. And when she used to smile, she used to have these eyelid rolls which develop, the hypertrophic orbicularis oculi rolls. And using in photograph B, using the Botox in the hypertrophic orbicularis oculi roll actually flattens it and causes the eye to open up during smiling, which leads to a good feeling of youth. This is not how we inject the Botox, but the results are very similar in the way we do it as well. Now, if you look at certain people who come into us, so this lady came into us and she wanted to know if we could fix her squinting, as she called it. But when you look at the light reflex, it's clear that there is no squinting as such. But what there is orbital dystopia. You can see that the right side of the face looks very different from the left side of the face. There's inferior scleral show in the right eye, which is not there in the left eye. Even the configuration of the eyes is very different. The right brow is also higher. And when people like this end up smiling, then you see that the hypertrophic orbicularis oculi roll on the left side actually makes the eye look even smaller when they are smiling. And when you put this into perspective with the fact that this particular lady is a model, you can see why she's so distressed. Now, in conditions like this, basically using Botox and fillers can give results like these. And this is the before and the after. And you can see, despite her smiling, now the under eye area is flatter and the eyes look much more symmetrical. It's not perfect, but it's definitely a lot better. And this was accomplished by using Botox and fillers. And you can do that without necessarily performing surgery, which can be a little unpredictable in these patients. There are also patients who will come in with eyelid bags. She's 34 years old. And the question that I always ask for the proponents of blepharoplasty is that even if you performed a transconjunctival blepharoplasty now, given the fact that her eyelid tissues are weak and there is a protrusion of fat, which can be seen in the under eye area, how many times can you perform blepharoplasty? So therefore, using fillers in these cases, and this is immediately post the fillers, you can see the injection marks. You can actually camouflage the mountain by injecting the filler below the valley. And by doing this in an appropriate manner, 15 days later, you can actually convert her to a situation where you can't even tell that she's had a procedure. Facial thread lifts are very critical and important for us. And this is a non-surgical treatment which is performed. So the facial threads are basically like rose stems, which have a lot of thorns in them, and they engage the superficial subcutaneous fat pads and pull the face up, thereby making the under eyes look much better. These are our workhorse lasers, which are very important as well. The carbon dioxide laser being utilized for facial rejuvenation, and the Q-switched Nd:YAG laser being used for the pigmentation, which a lot of Indians have, or the dermal pigmentation, which is seen in under eye dark circles. These are some of the results which can be caused by combination. Sorry, I'm going a little fast, but in the interest of time, don't have that much time available now. So as a result of which, using peels as well as using laser can make the under eyes look a lot better. So you fill with the fillers, you use the, that reduces the shadowing, makes the under eye look better. And then the use of peels and lasers makes the entire eye look much more natural and the skin merge better with the mid face. Now, in patients who come like this, many people would do surgery, but you can also do non-surgical stuff. You can do fillers, you can do carbon dioxide laser, and even though this is a slightly washed out photograph, fact of the matter is that you can actually cause the skin to become tighter. You can camouflage the fat bags and therefore make people look younger, even non-surgically. And of course, combination treatment is the way forwards. You can see crepey skin needs carbon dioxide laser. You need to also go ahead and use the botulinum toxin and the fillers. One person can have multiple problems, and therefore combining the treatments leads to a very, very good result. And of course, there are roles for surgeries as well. And patients like these, there's no point in doing fillers, doing actual skin removal, doing a blepharoplasty, making sure that the eyelid crease is created well, making sure that the mid-face lift has been done so that the mid-face also, which is a continuum of the lower eyelid, looks much younger. And using carbon dioxide laser can make people look much younger. And that's the same type of procedure which has been done in this sort of patient as well. Now, in combination therapy, when you see these sort of folds, sometimes you can also go ahead and do blepharoplasty. But in blepharoplasty, especially a subciliary route, the one thing that should not be done is an excessive removal of skin, because that can lead to a lower eyelid ectropion and lead to many problems in the future. And therefore, removing skin conservatively and then using laser. So laser in this case causes collagen formation. Laser also causes some shrinking of the skin. On the face, every millimeter is an inch, and therefore utilizing each thing appropriately to reduce the risk and provide the best results becomes critically important.
Dr. Could you please conclude, please? We're already over time.
Yes, of course. So all in all, I just wanted to say that it's very important to understand that there are multiple mechanisms of treatment, and if we can diagnose patients appropriately and treat the under eye issues in a synergistic manner, it really helps. And obviously having a wide armamentarium will mean that we don't have only a hammer in our tool. As one of my teachers used to say, if a hammer is all you have, everyone will start looking like a nail. Thank you all for your kind attention and a very patient hearing.
Thank you, Debraj, for having brought out that perspective of the non-surgical interventions in the management of lower lid aesthetics. Lower lid aesthetics, as we know, is much more challenging, and it's a part of a continuum of the mid face as well. So having an overall perspective is vital, and we will have the surgical part dealt with next And maybe then we can have some more questions from the audience and discussion. Let's have the next talk then.
Good morning. Is my screen visible?
Yes.
Yes.
Okay.
Yes, actually.
Thank you to BOA and the organizing team for this opportunity and the platform to speak on lower eyelid blepharoplasty. I think Dr. Debraj has made my job much easier because he's explained the technicalities of what are the different options available. So an overview of what I'll be talking about is the assessment of a patient with who is a possible candidate for blepharoplasty, and then the different routes, some complications, and adjuvant or adjunct procedures. So the point of a thorough assessment of a blepharoplasty patient is to know who is a good candidate and who is not. And if a patient is a candidate for a blepharoplasty, what is the ideal surgery and what additional things can be done. Four things that are important to know is to identify the lower lid fat prolapse, which is the most common reason patients typically come to us. The excess skin on the lower eyelid can also form what are called festoons and lower lid dermatochalasis. And to differentiate that from the fluid bags seen on the upper cheek area, which are the malar mounds, and also to be able to rule out thyroid eye disease. So when a patient typically requiring a blepharoplasty comes to you, this is what they are usually looking like. They're in their middle aged and have lower lid fat bags. One thing that I always do to understand what is the best route for them is to make them look up, and typically the lower eyelid bags or the fat prolapse worsens on up gaze, and when they look down, as the inferior rectus and the capsulopalpebral fascia tightens, the fat gets pushed back in, and you see that the lower lid fat bags improves on down gaze. Now, this is typically in younger patients, whereas in older patients, you can see that when they look up, it definitely worsens, but when they look down, it doesn't completely go away, and you still have excess skin lying there on the lower eyelid. So here, this excess skin that you see probably would require transcutaneous correction as opposed to transconjunctival, which would help in the first case. Also, you can see that the lower eyelid position is lower. There is an inferior scleral show, so suggesting that the lid is lagging, there is lid laxity, and possibly a lateral canthon tightening procedure may help in this case. Other thing, like I mentioned earlier, is to differentiate malar mounds and to identify where there is fluid. As you can see in this patient, multiple issues. There is brow ptosis, there is unilateral ptosis, bilateral dermatochalasis, lower lid fat prolapse, and malar mounds. So this is the whole works, and one must identify what is what and offer the treatment accordingly. One size doesn't fit all. Like Dr. Debraj said, oftentimes patients come to us having been recommended a filler injection elsewhere or seeking an opinion for a filler injection. These are two similar patients who came with lower lid bags or bulges. Now, if you see, if I draw an imaginary mid-pupillary line, lateral to the mid-pupillary line on the lower lid, there is this fullness, which is essentially the fat bag prolapse on the patient to the left. Whereas the younger patient on the right, it is more of a focal bulge that is seen medially, like the hills and valleys. It's analogous to the hills and valleys. So in a patient who has this lower lid fat prolapse extending across the entire lid, it may not be a good idea to offer a filler. As you can see, when she looks up, it worsens and accentuates. So using that to help to figure out which patient requires which procedure, the patient on the left underwent a lower lid blepharoplasty transconjunctivally, and the patient on the right had a tear trough filler, which helped smoothen her lower lid fat, lower lid tear trough deformity as well as the bulging. So I'll speak quickly about transconjunctival blepharoplasty. Even better, I'll show a short video. Assessment is important. Like I said, there are surface landmarks which are easily identifiable. Typically, we see 3 bulges on the lower lid. Each of them correspond to a fat bag, a fat pad. There is the medial, the middle, and the lateral fat pad, the medial or the central and the lateral fat pad. And between the medial and the central, lies the inferior oblique muscle, which is extremely important for us to identify during this surgery. Local anesthesia is infraorbital, and then I give infiltration over in the inferior fornix. 4 mm below the tarsus is where the incision is made through the conjunctiva and the lower lid retractors, and directly you have access to the fat pads. Now here, you have to be very, very gentle in opening up the fat pads. They tend to be vascular, and you tease them out and then excise them or transpose them depending on your comfort level. I prefer excision rather than transposition or repositioning. You open up the septae. The fat pads tend to be a little painful, so I always inject a little bit of anesthetic into it and then cut. And finally, when you excise them at the stalk, there could be a bleeder, so it's a good idea to cauterize it as it goes along. And finally, the same thing for the medial fat pad as well, which is usually extremely prominent in Indians. So they also appear as the largest fat pad. The same procedure of injecting before excising. And finally, the same for the lateral fat pad as well. Again, like I said, we need to be careful between the central and the medial to avoid damage to the inferior oblique muscle. 3 interrupted conjunctival sutures of 6/0 vicryl are taken. You can see immediately post-op there's an excessive hollowing, which usually fills up over time. It gives very, very good reproducible results, transconjunctival blepharoplasty, and patients are usually happy. Even if patients who might otherwise work with fillers, blepharoplasty offers a longer duration of effect, and therefore I prefer that in patients rather than getting injected every 12 to 15 months. Transcutaneous blepharoplasty has very select indications, and I'll quickly run through that. Typically in older patients with skin excess, as you can see in this gentleman, who came specifically, surprisingly, for a blepharoplasty. It's important to know how much of skin to excise. The minimum amount of skin that is pinched without altering the position of the lower lid, as you can see now the lower lid is not going down, is what you need to excise to make sure that there is no post-operative lower lid retraction or ectropion. Local infiltration, then I take traction sutures, always put in a corneal protector. And over years, I've shifted from a RF cautery to make the skin incision for lower lid blepharoplasty to a 11 number blade. Once that is done, the skin, a small strip of skin and orbicularis can be excised with the RF cautery. You directly have access to the septum and the fat pads, gradual dissection. And like, as you can see here, the medial, the central, and the lateral fat pad are very well delineated. Again, be conscious of the inferior oblique muscle that stays there. Conservative excision of the fat pads is important. You can always bulge a little bit, press a little bit on the globe to see how much more the fat bulges out. That is serving as a guideline to know when to stop removing fat. Meticulous closure is extremely important. Vicryl or any other absorbable sutures for the orbicularis, and then the skin wound is closed after appropriately redraping. This also is the surgical wound can give you access for lateral canthal fixation as well. Again, this also gives very, very good and reproducible results if done well without causing lower lid retraction. There is a faint scar which is unavoidable in transcutaneous, which remains a drawback for this route. Complications we need to be conscious about. Lower lid hematomas. Indians tend to have ugly subciliary scars, especially if they're taken with an RF cautery. So blade over RF, meticulous closure can help in preventing scarring. And if you see lid retraction occurring, prevent it by being, the best way is to prevent it, but immediate use of 5-FU or steroids, or if needed, corrective surgery should be done early so as to not compromise on functional outcomes later on. And finally, adjunct procedures. Sometimes, like was mentioned earlier, a blepharoplasty alone or a filler alone or Botox alone may not help, and you need to add multiple things to it. This is a lady with lower lid fat prolapse. She said her eyes looked tired and had bulges under the eye. I offered her a transcutaneous, conjunctival blepharoplasty, and she was thrilled. But you can see that there is a slight skeletonization. From bulging, now she's come to having a slight tear trough deformity. And like Dr. Milind Nayak has mentioned in his article, this is a patient who has a valley, a hill, and then again a valley. So this then can be smoothened out by smoothening the lid cheek junction with hyaluronic acid, and the eventual effect between the outcome from the before and after is very, very acceptable. So to summarize, we need to be a little careful in choosing these patients and counseling them and letting them know what is a realistic expectation. Post-operatively, it's important to identify who is a dissatisfied patient versus who is a difficult patient. And pre-operatively, you have to give full disclosure about risks and surgeries and show them multiple pre-post photos of different patients so that they understand what they're getting into. And as you can see from my presentation, the best way to always explain what you have done is to have photo documentation at every visit, which saves a lot of headache for you. So one size doesn't fit all. Counseling realistic expectations before the surgery, thorough assessment before the surgery, and knowing what works for which patient will help you get great outcomes with lower lid blepharoplasty. If there are any questions, I think we can take them at the end of the session. I will stop sharing my screen now.
Thank you, Akshay. That was a wonderful talk and covered all the aspects very well. Maybe a question now, and then we can go on to the next one.
Sure. Sir.
How often do you use the lower lid tightening along with a transconjunctival technique, with a transcutaneous technique? Because that's often an integral part.
Yeah. So in younger patients, they tend to require
who are more
less
often
frequently.
the transconjunctival ones.
Yes. So typically I end up using lateral canthal tightening through the transcutaneous route. It gives better access, and B, also the older age group is the demographics who have lower lid laxity and sagging that needs that correction. I am myself not very comfortable with lower lid tightening transconjunctivally. So even if there's a patient who has got who possibly is a good candidate for conjunctival, if they need lower lid tightening, I end up doing a transcutaneous one.
And what about the choice of fat repositioning? Would you do it in some cases?
Now I'm trying to shift, I'm moving towards fat repositioning as I see more patients who, come back with a little hollowing, possibly because of aggressive fat excision during surgery. So fat repositioning is a good option, but I just don't know about, fat, like Dr. Debraj said, is a little unpredictable. So I don't know about the long-term outcomes. So I'm a little on the fence there.
The only other thing that I'll re-emphasize, which you have already done, is the conservative excision of skin. And the problems arise, and a number of cases that we see are basically because the assessment is being done in a lying down position, which is different from sitting up position. So any excision should be more conservative than you think, and it should have been decided in a sitting position. So I think those two things will save us a lot of difficulty.
Right. Thank you, sir.
Thank you, Akshay. Wonderful presentation. We now go on to Kasturi for her talk on the upper eyelid blepharoplasty, which will complete the spectrum of the blepharoplasties.
Very good morning to all of you. Good morning, Grover sir, Bethariya
Welcome,
sir.
Kasturi. Kasturi has established herself as the doyen of aesthetic oculoplasty surgery.
Thank you, sir. So, Dr. Sumit and all members of BOA, I congratulate you for having this Sunday session on oculoplasty and covering all the topics with so good, speakers. So, I'll be making this topic very simple. Basically, I feel that this is a very common surgery which can be done by any other general ophthalmologist. But one thing I like to insist that besides having an aesthetic indication, this also has got a functional indication. And this is a surgery which usually involves the eyelid skin, the muscle, and the fat. And these are either excised, or they are being redraped, or they have been sculpted. So basically, this word has come, blepharoplasty, we know it is the eyelid, and the plasticos means mold. So what Akshay was showing very beautifully, he has shown, so we need to mold. We need to mold either the upper lid or lower lid. And the molding can be either in the forms of your repositioning or a customized excision. And today, this blepharoplasty happens to be the second next common procedure next to cataract. Like I know that most of the surgeons are doing this, and it has become a very common surgery for all the oculoplastic surgeons because of its both functional and aesthetic indication. But when I talk about blepharoplasty, one should always remember basically globally we have only two types of eyelid. One is the Caucasian and one is the Asian. And when you look to the eyelids, there's gross difference between the two. Like you can see the difference in the tarsal height, the difference in the thickness, the difference in the the positioning of the crease. So we need to titrate, we need to customize whether we are doing blepharoplasty in someone having more of a Caucasian orientation as to someone having more of an Asian orientation. So as I have already shown, I think many of the lectures I have shown this is a very simple surgery, but the most important, you need to have a good marking. The only challenge when you do an Asian eyelid is number one, there can be asymmetry of the crease, and number two, the crease usually comes out after 2 to 3 years. So the challenge is that you have to do the surgery where you can give them a permanent crease, number one, and along with it, you might have to overcome many of the adjunct, aesthetic concerns, and may require some aesthetics, procedures extra. So the first you as usually remove the skin, then you remove the muscle, and then you I'm going a little fast, then you need to expose the medial and the central fat bed, and you customize. It depends. If you have a full thickness skin like this, you need to excise the muscle. But in case you have a hollowness, I don't think anyone will excise the muscle. So the best way is you just customize and excise some of the central fat, and this medial fat, you can transpose it. Like many times, I think in future, I can show you some of my videos. What I do, the medial fat, I transpose it and I retain it when I see in a eyelid patient. So like in my experience, what I have done, like initially all of us are very aggressive in, accessing the fat. But now one very important consideration, we need to see that there should not be a delayed post-operative hollowing, usually seen after 5 to 6 years, or the lateral hollowing or the lateral fullness that needs to be retained. So the end point of the surgery, which I already show, is the slight eversion of the eyelashes. As you can see, this is a non-operated eye, eyelashes are straight, and other being the operated eye, you can see the slight eversion of the eyelashes. So this is what I have already mentioned, the one of the most common, especially in Northeast India or in the very north of India, one of the most important indication is the eyelid crease. So the formation of the eyelid crease is very important because you need to give them a permanent crease, and the crease should be seen even in the lateral case. You should not have something overlapping out here and the crease is not being seen well. And many times it is difficult to maintain a small crease as compared to a bigger crease. So the crease both in the front view and in the lateral view, giving a very good tarsal pleature is what is the important requirement. But many times what we see, like in this lady out here, you can see she has a single crease and she doesn't have the crease on the other side. So these are more challenging because now it should be very symmetrical and you need to touch both the eyelids in order to make a more symmetrical, like how in Marcus Gunn, we need to touch both the eyelids. In such situation, when you have an asymmetrical lid crease, it is always better to touch both the eyelids and to have a very symmetrized lid following the surgery. So this is another patient with the asymmetrical lid crease that can be seen here. And another very important indication is the lash ptosis, because they have the overhanging of the skin here and which pushes the lash touching the cornea. So you need to do a surgery, you need to lift the lashes so that this also has got a function indication. This is another one boy, you can see there's so much of the eyelashes touching, and this is the same patient, you can see immediate, this you can still see the suture here approximately a week following the surgery, where what I feel that every case of upper lid blepharoplasty, especially when you do an Asian upper lid blepharoplasty, you need to put the braces suture, which I'll be showing you. So another important indication which has got both a functional and a cosmetic is when you see a very prominent gland, lacrimal gland, and you can see the gland has been prolapsed. So as usual, you do the different steps of the blepharoplasty. And this is a lacrimal gland. You can see the gland is totally prolapsed. By looking at the color, you can make the difference. The fat is little yellowish and the gland is little white. And you need to push it inside and you need to put a different type of suture. Initially, I used to Prolin, but I feel the Polydec is a good material. And I usually put 1 or 2 matrix suture. You take the first bite through the capsule and the pericapsular tissue, and the second bite, what you do, you pass it to the periosteum. So once you pass this suture, this is usually a matrix suture, you can see the gland remains pushed inside, and once it is pushed, I hardly have seen any recurrence. Usually you can give an additional 2 to 3 sutures. So with this matrix suture, which is passed through the capsule of the gland, and the second suture through this periosteum, you can reposition the gland. So likewise, along with it, you can give another 2 or 3 sets of suture. And here in this case, only you can customize and titrate some, you excise some amount of fat. But as because she already has got a beautiful crease, you don't need to form any lid crease. And this is how at the end of the surgery, very customary, you do not excise more because you don't want her to have a skeletonization, which Asha has shown so well. So this is the girl, the same girl, this is before and after the operation. And you can see that aesthetically and also the volume has all restored. We have not excised much. And so you can see the lateral fullness is still there, and especially in elderly people like her, when you want to retain the lateral fullness. And this is what I have seen. If you excess too much of fat, this gets lost in the subsequent years. So what we do, we usually use the braces suture. Like braces suture is something very simple, but if you want, you usually need to pass the suture through the lower end of the orbicularis and then the upper end of the orbicularis and pass it through the arcus marginalis. So 2 to 3 sutures like this, it really helps to retain the fullness. Why it retains the fullness? 2 ways. What it does, number 1, it leaves the lateral eyebrow and the roof, which is just above it, it makes a barrier for the roof to come down. So that fullness, the sub-brow fullness remains retained if you give an additional braces suture. As you can see here, even like in most of my surgeries, along with a routine blepharoplasty, I usually give the braces suture to retain this sub-brow fullness, which is usually evident. So, and sometimes these are real challenging cases. These are the cases which there's so much of loss of skin elasticity, and this usually occurs. Sorry, I think I have misplaced it. Okay, it's fine. Can you see my slide? I think it got disconnected, right? It's okay.
We cannot see your slide at present.
I don't know what happened. Something has happened. Okay, let me see. This is only the last slide. Ignore. But it is okay, even if it is not opening. And so these are some of the challenging situations that can happen. And if so, like when we have an like situation like this with a droopy hood, we need to do a very, very extended blepharoplasty. And in such situation, what, can you see my slides now?
No, we can't.
No.
Stop sharing. Then, okay, I will not waste time. So there is something known as extended blepharoplasty, where normally you can at least see me. Sir,
Yes.
can you see? Okay,
Yes.
normally when we do a blepharoplasty, we need to have an incision just a little medial to the lateral canthus. But when we do an extended blepharoplasty, the lateral end must be at the lowest point of the lateral hooding. So the first point, as usual, the 10 millimeter, which we give for the crease, but the lateral point should not end at the lateral canthus. It should end at the lateral point or the lowest point of the hooding. And we need to form an obtuse angle, approximately a 15 degree, and do the rest of the procedure. Along with it, we always need to do a LPS plication, because LPS plication helps along, because these are the patients who will have some amount of ptosis. So along, since we are already doing an anterior approach, if we do a LPS plication, it helps also to overcome the little amount of ptosis. So these are some of the different ways of surgical adjuncts along with the internal bropexy. But the main difficulty, especially what I see, that sometimes there can be an asymmetry of the lid crease, number 1. The lid crease may not be permanent, at which we usually see in many of the situations. And number 3, I have seen, like, especially I have seen many, the new people starting doing, they have some, even I could see some amount of lid retraction following a blepharoplasty. So if we know the anatomy and if we respect the tissue, we should not overdo, better to underdo. And I think that gives a more better long-term result. Thank you very much.
Thank you, Kasturi. That was a wonderful exposition. A lot of your experience brought in. And of course, we need to understand the differences that exist in the management of so-called Asian, which we should probably call Oriental if we consider ourselves also as Asians. So that blepharoplasty and the blepharoplasty in the rest of the Indian population. Because maybe the central pad of fat does not need to be excised in most people. The lacrimal gland needs to be handled only largely in cases of dermatochalasis with lacrimal gland laxity and so on. And the lid crease formation is not needed in most cases of blepharoplasties, which are being done for non-oriental eyes. But a wonderful exposition. She gave all her experience, all the important finer points in the management. The older patients are really a challenge, and you really need to make sure that you don't make them look 16, right? So thank you. And we'll go on to the next talk then by Dr. Milind Naik. Milind will talk to us on medical and surgical management of facial spasm. Milind is again a pioneer and a teacher for a whole generation of oculoplastic surgeons, and a wonderful teacher and speaker at that.
Good morning, everyone. Dr. Betharia, Dr. Grover, and my colleagues. At the outset, I would like to thank Dr. T.P. Lahane sir, Ragini madam, and even Sumit for putting up this great program along with Dr. Honavar. So I would be talking about management and just to respect the time allotted, I will focus on three aspects. One is how to identify the spasm. Second is the injections. And third is a little bit about myectomy. So for identification of spasm, I always suggest and teach the fellows to follow this simple quadrantic algorithm. So if you assume nose as the center of your face, you can divide the face into 4 quadrants. And if your spasm is just within one quadrant, that too a single eyelid, then that is more likely to be a myoclemia. If you have the upper 2 quadrants involved, that is benign essential blepharospasm. If you have either side of the face involved, like a upper and a lower quadrant, then that's hemifacial spasm. And if you have a BEB along with lower facial dystonia, then that would be called as a Meeks syndrome. So you pretty much can fit all the facial spasms into this. Here is a short video and a slide of botulinum toxin being used for a patient of benign essential blepharospasm. Here your site of injections might vary based on your training and specialty, but usually we have a couple of eyelid spots and the brow spots. And the lower facial can be added if the patient also has Meeks syndrome. So 2 to 3 millimeters above the punctum and below the punctum. Sorry. 2 to 3 millimeters above the canthus and below the canthus. Another point, a centimeter lateral to the lateral canthus is what I usually follow. These 5 spots for the eyelid. And brow would be depending upon how much is the brow protraction in a particular patient. On similar lines, hemifacial spasm affects only 1/2 of the face. In these patients, you have to do imaging to rule out a vascular loop syndrome. But this is a lady who was treated with botulinum toxin, and you can see the reduced spasm. Although it doesn't disappear fully, but the twitching definitely reduces a week or 2 after the injection. So the sites which we talk about in hemifacial spasm, apart from the eyelid and the brow indication areas, would also be your zygomaticus major and minor at its upper end, and the levator labii, which is usually injected inferomedial to the nasolabial fold. And mentalis and platysma can be injected based on what the patient wants. Just to touch upon a fact that here you have option in the upper eyelid of injecting either pre-tarsal or pre-septal. And we recently concluded a split phase study where we did pre-tarsal on one side and pre-septal on the other. And we found that the pre-tarsal is the one which gives a longer effect. The patient is happier with this, and it has low incidence of ptosis, but it has higher incidence of lagophthalmos, which is short-lived after the injection. Here is a case of apraxia of lid opening, where you can see that there's a lag between when you ask him to open the eye and when he's actually able to do that. So there's a confusion between the levator and the orbicularis, and this can be life-threatening for the patient. And the botulinum toxin injections for these patients have to be slightly different. You have to kill the entire pretarsal muscle right up to the lateral canthus. So here I'm injecting 3 spots instead of 2 in the upper eyelid, a medial, a central, and a lateral. And one more additional is given at the lateral canthus. So the closer you are to the lashes, the better is the benefit in apraxia. Sometimes apraxia is unmasked after a treatment of BEB, and if these patients still complain of not being able to open the eye, then you can just give them a central eyelid injection at 2 weeks, and that takes care of it. So you can see the reduction in that lag he had. He's not absolutely normal, but he's far better than what we started off with. Similarly, post-facial palsy patients who have reduction in palpebral aperture can be treated with Botox. Finally, coming to orbicularis myectomy, which could be limited or extended, you basically have to separate the orbicularis muscle from the skin, carefully preserving the dermal plexus of vessels and the septum, and remove the entire muscle. And here I'll share a new concept that we are trying at the institute. We have just initiated a study, which is a nerve integrity monitor being used to do fine peripheral neurectomies while you are doing a myectomy. So we first mark the frontal nerve, and then we go on searching for the terminal branches of the nerve while we are doing the myectomy. So we have initiated a study where we would be doing a split phase of traditional myectomy on one side and a NIM-assisted myectomy on the other side, and would be looking at the results. So just to summarize, we talked about the quadrantic algorithm to identify spasms. Toxin pretarsal is better based on the study we conducted in-house. And myectomy, we have NIM-assisted version to look forward to. Thank you.
Thank you, Milan. Beautiful classification, covered very succinctly and with all points covered well. Any questions from any panelists, any of the moderators with any questions from the audience for any of the previous questions? Otherwise, and we can proceed on to the next talk.
Yes, sir. We can move to the next talk.
Okay, so the next talk is by Dr. Girish Nehete, who will give us an overview of ptosis simplified.
Yes, thank you, sir. Is my screen visible?
Yes, yes, Girish, go ahead.
Thank you, sir. Thank you, BOA and MOS for giving me the opportunity. I'm little nervous to present myself as I got slot in stalwarts of the oculoplasty. I will be talking about ptosis in a simplified manner. Ptosis is a used topic, so I will try to cover it as my best. It is grossly can be divided into the congenital and acquired variety. In congenital ptosis, it can be simple or with synkinetic movements, Marcus-Gunn jaw winking phenomenon, and with hypotrophia. It is also called double elevator palsy. In case of acquired ptosis, there are different varieties like myogenic, neurogenic, aponeurotic, mechanical, and traumatic. Detailed history of the patient is important to arrive at the diagnosis. Old photographs are also important. Thorough examination is important to arrive at the diagnosis and perform the surgery to get the optimum results. I will not go into the details of the examination. I will show some of the ptosis gallery. Consent has been taken from patients. This patient, 3-year-old patient, come with a chin elevation and drooping of the both lids. It is a congenital ptosis. Frontalis sling surgery was done to correct. Its posture also get corrected post-operatively. This is a young lady, comes with both eye ptosis. On looking down, there is a conspicuous lid lag. So lid lag is also sign of congenital ptosis. Another case of congenital ptosis presenting with whole family blepharophimosis syndrome. It consists of blepharophimosis, severe ptosis, telecanthus, epicanthus inversus, and sometimes lower lid ectropion. Surgery was carried out, double Z plasty and frontal sling surgery was done to correct the ptosis. And patient was also having a high hypermetropia, was given spectacles. Another case of blepharophimosis which I encountered in the OPD. So we have done studies YB plasty and frontal sling surgery in one-step surgery only. So we could get a good result. This was the case of the acquired phimosis. The patient was from tribal area. He was having a trauma by the wild animal. So we have divided the upper and lower lids and tried to form the palpable aperture. Lower lid tensile flap was done, and we could get this result. Another case of severe ptosis, boggy swelling over the upper lid and multiple cafe-olate spots suggest neurofibroma of the upper lid. In case of these patients, debulking and sling surgery can be carried out, but most of the time it recurs. Young boy come with the ptosis with irritable eye, and eversion of the lid reveals the diagnosis. There was a giant papillae, cobblestone papillae of the palpebral conjunctiva. After giving conservative line of treatment, ptosis gets corrected. Very old lady, almost 85-year-old lady, come with the severe ptosis and boggy swelling, cystic swelling over the upper lid. So palpation and CT scan of the orbit revealed there is a cystic mass inside the orbit. We carried out the surgery to take out the mass, and she had underwent retinal detachment surgery 25 years back. So in the cyst, scleral buccal and 40 suture was there inside. So after excising the cyst and reattaching the levator aponeurosis, we could get this result. Young lady presenting with the mechanical ptosis, swelling over the purplish black swelling over the upper lid, excision and the tensile flap technique gives good result. Old age man presenting with boggy swelling over the upper lid, palpation and eversion of the lid leads to the diagnosis of the pinkish mass inside the eyeball. It was a lymphoma of the orbit. Young lady presenting with the boggy swelling over the upper lid and somewhat hypoglobus. So eversion leads to the diagnosis. Some purplish cystic mass was there inside. So we have advised a CT scan of the orbit. There was a cystic mass along the roof of the orbit. So 2 injection of the injection triamcinolone acetate was given, and we can make out the supratarcal sulcus post injection. Old man presenting with the moderate ptosis within a almost 6 months period, and eversion of the upper lid again revealed the diagnosis. We have sent a mass for biopsy. It was a squamous cell carcinoma. The patient actually lost for follow-up, but again came after a few months. The exenteration was done by oncosurgeon. A middle-aged person presenting with the severe ptosis in the OPD. So simple bedside test like ice pack test can be carried out to reveal the diagnosis. So it was a myogenic ptosis. So in case of that, ptosis can be unilateral, and defective convergence is the early feature. Another case of myasthenia gravis. Treatment is conservative. Oral anticholinesterase inhibitors and oral short course of steroid can be given. The young boy presenting with the severe ptosis, covering the normal fixating eye reveals the diagnosis of pseudotosis. nowadays many of the patients presenting in the OPD post-COVID because of third nerve palsy. So this is one of the case of third nerve palsy ptosis. The lady came with the ptosis with acute onset. Nothing much significant find out in examination and investigation. So we have tried a short course of oral steroids, and within a few weeks, our ptosis was corrected. Old man presenting bilateral ptosis was basically by brow ptosis. We have carried out brow plasty and blepharoplasty to correct the ptosis. So one can easily make out, looking at the photograph, in this patient, there is ptosis and eyebrow is on lower side. Actually, in case of ptosis, the eyebrow should be on the higher side. So it was a clear case of hysterical ptosis. After some or counseling, patients was ready to open both eyes. So to conclude, management of the congenital ptosis is surgical at the earliest possible to 2 years or 3 years. And in case of acquired ptosis, always evaluate, always feel free to palpate and evert the upper lid, and necessary investigations can be carried out for the treatment of the cause and surgical management. Surgical options include mild ptosis with good levator function, excellent levator function, fascinella servata is carried out. In case of moderate ptosis, good levator function, levator resection can be carried out. In case of severe ptosis with poor levator function, frontal sling surgery. So to conclude, as my mentor, Dr. Nitin Trivedi, is used to say, the best results will be obtained by fitting the operation to the patient and not the patient to the operation. Thank you.
Thank you, Doctor. Thank you, Dr. Girish. That was a very nice collection of cases, some very nice results, including the one particularly with the telecanthus, traumatic telecanthus, was very beautifully done. And you need not be nervous. We all have a long way to go in learning, and you are better than what I was at your age. We'll go on to Dr. Shubra Goyal, who has a vast experience in oculoplastic and aesthetic surgery, and we always look forward to her and very nice talks. So she talks to us on management of ptosis by a small incision.
Thank you very much, sir, for your introduction. And at the outset, thank you, Dr. Lane, sir, Dr. Ragini, Sumit, and Dr. Hunawar for putting up such a wonderful show and having me on board amongst all the esteemed speakers, colleagues, and friends. So my talk has been, I will be sharing some thoughts on small incision ptosis. These are my disclosures. And before we jump into any procedure, and it holds true for ptosis as well, that we need to understand whether it is really ptosis and should we really be operating, and if yes, how? So I think we all have our shares of experiences and cases where we have diagnosed it something else and we'll end up doing something else. So it is very important to understand what are we dealing with. So I'll just touch upon, in view of blepharoptosis, is that, for example, this is the patient who was sent for blepharoplasty or brow lift surgery, but actually, for ptosis surgery, and what she actually had is brow ptosis, and her MRDs were equal and she didn't need a ptosis surgery. Another patient who walked into the clinic saying that her left eyelid is drooping, but what she had was retraction in the other eye, and she was a case of thyroid eye disease when was examined in detail. So I'll just focus my discussion on what has been simplified in terms of dealing with ptosis surgeries amongst various techniques and methods which have been there in the arena of surgical discussions. It started way back in 1992, where the aponeurotic ptosis surgery was tried to make very simple with a simple tuck suture. And then in 1999, where the Wisconsin group came up with the small incision external levator repair surgery and validated the results. Why it is more, it's better than the routine or the conventional ptosis surgeries because it gives us a better height contour, and the recovery and the postoperative edema is lesser as compared to the conventional procedure. Now, it may vary in surgical hands, but in general, the small incision surgery has better recovery and faster recovery and lesser edema. And when it was compared with the small incision was compared with the traditional approach, what was noted is that the height effectivity or the contour was, the height effectivity was equal versus the contour was superior, and it was much quicker procedure by the same surgeon who did a control study on the same patient with bilateral ptosis, one with conventional and one with small incision surgery. Now, this kind of a procedure works best when you're dealing with involutional ptosis or anophthalmic sockets who have aponeurotic ptosis, deep superior sulcus, where you don't want to have too much of excision of the skin or dealing with the orbicularis muscle. And definitely in younger patients, even in resection cases, I've tried few cases and it works wonderfully. So this is a short video which I'll be sharing. So if the incision can be smaller than what I have taken here, it depends on case to case. So you can titrate the incision size based on the case we are dealing with. Usually, if patient has a heavy dermatochalasis, it's better to take a little longer incision because you have a better exposure. And the steps remain the same, where you expose the tarsus, go and expose the aponeurosis, lead to the preaponeurotic fat, isolate it, look at the junction, and just take the adjusting sutures. Usually, a single tuck sutures does wonders. But if there is too much of dehiscence of the aponeurosis, even 2 tuck sutures can be taken. But the small incision surgery is usually beneficial with a single tuck sutures. So this is the result at the end of the procedure on table, and you can combine it with or without extra excision of the skin if it may require for the bilateral adjustments and if a patient has an extra dermatochalasis. So these are few of the examples where the procedure was carried out. This was a simple case of mild aponeurotic ptosis with the brow ptosis, and this is how patient was on day 3 after the procedure. So you can see the amount of post-operative edema, the recovery is much faster or much better as compared to the conventional full thickness of full incisions which we take. Another individual, very old, with bilateral ptosis, with severe brow ptosis, and this is what we had done for him. Again, a very, very, I think the incision was not more than 2.5 to 3 millimeters to per se, and I was just chasing to the aponeurotic, just single tuck, and that's all we did for the patient because he was also on anticoagulants, and it was a pretty helpful procedure. Another patient, post-glaucoma surgery, had a blep, so we had to do minimal for him and just did a single tuck small incision procedure. Patient with blepharopalaces also can be dealt in a similar manner. If there is not a large amount of fat prolapse or lacrimal gland prolapse, this surgery can work wonders, where you can have a minimal excision of the skin along with the without the skin excision in this case. So these are some of the articles which were published or chapters which were there, which I had the privilege to write on, and one can go through. This is more for the benefit of the postgrad students. So some of the tips in the small incision ptosis surgery is that we have to walk up to the aponeurosis and reach the superior tarsus ligament. Slightly placing the suture medially always gives a better contour whenever you're doing a single tuck suture, and do not consider lid crease as a very important factor in such cases because we are just going to give a small cut, and we really are not disturbing the lid crease in such cases. Thank you very much.
Thank you so much, ma'am. Thank you, ma'am. That was really simplified and small incision that really works well. Ma'am, just a quick question. How, in case you need to, if there's a slight under correction for revision, do you still prefer to go in with a small incision, or then do you make it a larger
No, if there is an undercorrection, you will know it on the second or third post-operative day, and within the 1 week period is where you will just go back and titrate your sutures, and it's exactly the same incision and the same site, because these are the cases where just there is a dehiscence. So it's all about titrating your sutures. And I haven't done the adjustable sutures in a small incision ptosis surgery because it doesn't make sense. But yeah, I don't, and in my hands, probably if I have done, let's say 10 surgeries, the percentage of revisions would be 1 or 2 cases, because it's pretty accurate on table, because you're just doing a single duct suture.
Okay. Thank you, ma'am. And I have the pleasure of introducing Professor A.K. Grover, who's been a teacher of generations and literally a teacher of teachers. He is, of course, at Sir Gangaram Hospital and Vision Eye Centers in Delhi. And he'll be talking to us on hard palate grafting for malpositions.
Thank you, Akshay, for your kind words. I hope you can see my PPT.
Yes, sir.
So I'll be moving out of line with what has been presented so far, ptosis and aesthetics. I'm talking about the use of hard palate grafting for eyelid malpositions, which I found quite useful. I only started using it during the last 4 to 5 years and have done about 5 cases so far, and I'm enjoying using it. So the hard palate graft is indicated for cases which have a middle lamina or a posterior lamina shrinkage, causing eyelid retraction or entropion. This is particularly true for the lower lid, and the cases include the inflammatory eyelid retractions as in trauma or in previous surgical cases, previously operated cases which have not worked out. Thyroid eye disease is another common indication where lower eyelid retraction can be troublesome. And some of the blepharoplasty cases where anterior lamina is not the problem, but the middle or posterior lamella is. It is also useful in eyelid and socket reconstruction, but we are going to talk about the entropion and eyelid retraction cases today. So what are the options when we judge there to be a middle or posterior lamina shortage and we need to replace them? We often use spacers such as the scleral grafts, ear cartilage, and materials such as allodum, all of which have their own shortcomings. And we use for the reconstruction both of the mucosa as well as for the support, the nasal mucocartilage or a tarsoconjunctival flap or a graft or a hard palate graft. All of them have their own merits and demerits. The hard palate graft has some advantages. It provides us both the mucosal lining as well as the stiffness required that obviates the need for a support like tarsus. It's easy to harvest and you get enough amount that you need. It is autologous, so problems associated with a graft taken from somebody else with the viral issues and so on and so forth are taken care of. It takes up very well, and shrinking is very minimal, so you don't need to use too much excess, and complications are rare. So what you need to assess is that there is a shortage, there is an inability to stretch it. Especially if you stretch it upwards, you will notice that you can't stretch the lid, and you differentiate it from those with a shrinkage in the anterior lamina, and then you know that it is possibly a posterior lamina that needs replacement. You also need to look for eyelid laxity, which also needs to be addressed at the same time. Let's look at the surgical technique. The hard palate graft harvesting is the first critical step, and the location where you take it from is medially, just short of the middle raphe, anteriorly up to where the soft part or the rugi start, laterally right up to the part where the curvature changes for the teeth, and posteriorly up to the junction of the hard palate and the soft palate. So there is a considerably large part that you can take for, and if you need bilateral, you can do it bilaterally. That is the advantage. I will start by marking an incision, which is a couple of millimeters below the tarsal border. And I use a traction suture to rotate the eye upwards. Then you carry out a dissection. Now, this dissection is carried out between the orbicularis oculi and the septum and the retractors. And then you also need to make sure that your retractors are free. You can give lateral incisions to take care of the horns or lateral or medial supports of the lower lid retractors. Make sure that this is free. Look at the defect that is present and then thin out your graft on your fingertips. Make sure that you remove the glandular and the fat tissue on the undersurface and size it about a millimeter larger or millimeter or two larger than your requirement of the width and the length. Make sure that you have enough to go medially, adequately medially, because a shortage on the medial side is often a bad result. And make sure you have enough of it. So you give your incisions from somewhere near the punctum to right up to the lateral canthus. And then you place your graft in, usually with some 6-0 Whitefield sutures. You can use combination of interrupted and continuous. I've used interrupted here. Let's look at this short video. So this is a lower lid retraction that you can see due to previous trauma, scarring, failed case earlier, used traction sutures and covered the cornea to protect it and passed a traction suture. Now this is the marking. So you'll see extends from near the punctum up to the lateral canthus, and you open up with an RF or a knife. We've used some xylocaine with adrenaline, given it some time in order to get good hemostasis. And then a dissection is important. It is important to lyse all adhesions. So you go right up to the inferior orbital margin to make sure that you've freed the retractor, you've freed all the adhesions and given the lid all the freedom to move. And now we are thinning down the graft so that it takes up well. You leave behind just about 1.5 millimeters of thickness, but it has enough firmness. And you measure the size and choose the size that you would need, and you place it in position. And then anchor it well. Make sure that you are maybe 1 millimeter or 2 higher than the inferior limbus when it is positioned rather than much higher, because you don't get too much shrinkage in these cases. So you can put in the sutures as you would anywhere, and that completes the technique. You have to guard against infections, very rare, but a hematoma does take place sometimes in this area. So you have to achieve a good hemostasis at the end of the procedure and post-operatively make sure that they avoid hot things or things with salt so that they are comfortable. Graft necrosis is rare, pain can be common, and they can be over or under correction. So those have to be particularly guarded against. So this was a patient who had had multiple surgeries before and had a bad lower lid retraction. There was a restricted upward motility as well. First, a squint surgery was done, and then a graft was placed, and we could get a good position as required. And it has really transformed her life. So she's very happy with her present appearance. This is another illustration of a patient who's again had multiple surgeries following a trauma, including for telecanthus, including for ptosis, including for multiple procedures for entropion, which was not getting corrected. She still had entropion and the downward displaced canthus. So we realized she needed more filling up of the inferior conjunctival area with replacement. We repositioned the lateral canthus by breaking up all previous attachments, making new attachments, and making all the adhesions a long procedure, and combined it with a graft hard palate, large hard palate graft, which gave us a much better position and corrected her entropion, which was otherwise incorrigible. So hard palate graft is a valuable tool in the armamentarium of us for correction of eyelid malpositions in appropriate cases. Of course, you can use it for reconstructions more often in the lower rather than in the upper lid, but for several other situations, it is a valuable tool, and we should have it as a part of our armamentarium. Thank you.
Thank you, sir. That was really enlightening. I have the pleasure of inviting the next speaker, a very senior oculoplastic surgeon in Mumbai and a close friend of ours, Dr. Rupali Sinha, who will be speaking on predictable outcomes in LPS resection surgery. Dr. Rupali, we are seeing the speaker view.
I'm sorry.
We are seeing you, which is most welcome.
Thank you, sir. No, unfortunately, Geo is just refusing.
It's okay. I think even if speaker presenter view is happening, at least we'll see something.
Yes, no, the share screen is just not happening.
Excellent.
Has it come in now?
Yes, now we can see it. Thank you.
Sorry. So good morning, everybody. Thank you, Dr. Lahane sir, Dr. Ragini ma'am, Dr. Munawar sir, and Sumit for giving me this opportunity. I'm going to talk about predictable outcomes in LPS resection surgery. Thanks to Dr. Shubra and Dr. Girish and Dr. Kasturi, we've already covered most of ptosis. So I'm going to just talk about how to improve the outcomes in the aponeurotic surgery. First is the lid crease. We will mark the lid crease with matching it with the other eyelid. And then going on to the surgery, once the lid crease is marked and we've given a local block, we take a skin incision and we will dissect out the orbicularis muscle. Then finding the LPS aponeurosis after opening up the orbital septum, the LPS aponeurosis is then dissected out from the tarsal plate and the underlying molars muscle. An appropriate suture at an appropriate level, we take a suture with a 6-O-proline, the central suture taken first. Care should be taken that we don't take it through the entire thickness of the tarsal plate, and we attach it in the middle 1/3 of the anterior surface of the tarsus. And we'll check for the lid contour. If the lid contour looks acceptable, then we take the medial and the lateral sutures with the same 6-O-proline. This is a monocryl with which the lid crease is being formed, taking the orbicularis and the levator, and then the orbicularis again. And the skin can be closed with proline, either interrupted or continuous sutures. Now, the ideal result of a surgery would be symmetry not only in the palpebral aperture height, but also with a good contour of the lid and with symmetry between the eyelids, the eyebrows, and the eyelashes with good blinking. So for this soft tissue, which should look symmetrical, we should take care of preoperative evaluation in seeing the position of the brow. As we can see in the left eye, the brow on the right side is elevated, probably because of overuse of the frontalis. Also, the important measurements that we should consider are the brow fat span, the tarsal platform show, of course, the MRD1 and the palpebral aperture height, and take care to look at the position of the lashes in case there is lash ptosis. This is the post-operative, this is the result after a surgery, where we can see more or less the eyebrows come back to the same level. And not only is the palpebral aperture height better, but the brow fat span and the tarsal platform show are also somewhat equal, giving it a much better result. We should also take care to show to the patient that they have inferior scleral show if they have it preoperatively. So this is the pre and the post of the same girl who underwent a left aponeurotic ptosis surgery. a similar patient with aesthetic results, not just because of the palpable aperture height, but by taking in view all the other aspects of the soft tissue as well. Now, what does one do with overcorrection? For overcorrection, we can manage either just by massage, by warm compresses if it's little, if it's a small amount of overcorrection, or by doing lid tugs while the patient is looking down to teach the patient how to tug at the lid and make the sutures on the aponeurosis a little loose. Sometimes we even need to operate such patients, and especially a temporal suture. In case we're doing a smaller surgery or lesser correction, we may even not take the temporal suture if there is appropriate correction just by taking the central and the medial or the nasal suture. If there's a patient who has multiple lid creases because of prior surgeries or lash ptosis or both, like in this lady, then we can take out a small sliver of the skin where these multiple lid creases are if there is excess skin, and then make an appropriate lid crease. For the lash ptosis, just like Dr. Kasturi had shown in her wonderful video, we take an incision through, we take a suture through the lid crease incision, which is closer to the lash line, and then we will attach it at a higher level onto the aponeurosis, LPS aponeurosis, and look for eversion of the eyelid margin so that we correct the lash ptosis. For a better result in a Herring's law positive ptosis, in the sitting position, we can mark the palpable aperture height of the non-ptotic lid and keep that as the correction endpoint when the patient is on paper. And this, of course, should be demonstrated to the patient along, preferably with the patient's own video, that this is what is happening when we are elevating your lid. Your normal eye is coming down a little. And that's the result that we are going to achieve. So this could be an important part of the documentation in Herring's law. I think if we take care of all of these factors, then we can get very good results, very predictable results in ptosis. Thank you.
Thank you, Dr. Rupali, and thank you for the social distancing message also. Our last speaker, but definitely not the least, is Professor Betharia, who is the incoming president for the Oculoplasty Association of India, and has been a teacher for generations. And he'll be giving us his wisdom on 10 pearls in ptosis surgery. Professor Betharia.
Sir, unmute yourself.
Am I audible now?
Yes, sir.
Thank you very much, Dr. Ashok, Dr. Akshay Nair, and all the office bearers of the Bombay Ophthalmic Association for having me with all of you. Most of the points are covered in ptosis surgery, but I would like to emphasize my 10 pearls. So in different parts of the ptosis surgery, like fascicular servet, I'll give you some pearls. Then Levator surgery, then Sling Surgery, and then excision of the levator when you want to abolish the Marcus gun phenomena. So coming to the fascicular servet operation, as you know, LPS action very good, 10 millimeters and 1 to 2 millimeter of ptosis. I think our method, which we devised right back in the year 1983, which was published in BJO and was an outstanding article, and also published in Yearbook of Ophthalmology 1984, works very well. The important point here is me and Ashok and late Dr. Kalra were the authors of this paper. And here what we have done is we have used, instead of Putterman's clamp or the artery clamps, we have used 2 sets of sutures. The advantage of using the 2 sets of sutures is the posterior set of sutures is useful for holding when you are suturing. And you can excise 4 millimeter of the tarsal plate very nicely from one end to another, which gives rise to minimum notching, and you are able to get a good contour. And we have given a subconjunctival suturing so that to avoid the corneal abrasion, because the central tenting and the corneal abrasion, these were the two problems of the original fascicular servant operation. So I think this operation works very well for small amount of ptosis, 1 to 2 millimeters with 10 millimeters of LPS action. Now coming to the levator surgery, you see the main problem of levator surgery is undercorrection. Undercorrection is a rule and overcorrection is an exception. So I think to get rid of this problem of undercorrection, what we should do is we should plan for overcorrection in all cases of congenital ptosis, wherein you find the levator action is usually, say, 5 millimeters, 6 millimeters, 7 millimeters. These are the levator actions in most of our cases of congenital ptosis. So, and other important thing here is how will we increase the amount of correction? That means we have to go to the superior transverse ligament of Whitnall, identify the superior transverse ligament of Whitnall, cut the horns generously and mobilize the muscle, because once we cut the horns and mobilize the muscle, that will reduce our lid lag, and then we can pass the sutures somewhere near the superior transverse ligament of Whitnall, so that we are able to give a good correction of these cases of ptosis. I think there is some disruption in this. There is some disruption in my talk. Am I audible now?
Yes, sir. We are audible.
Okay. Okay. So what we have to do is, the main thing in case of congenital ptosis is the adjustment of the eyelid onto the limbus. So we have to adjust our eyelid at the finish of the surgery, and if we are doing it under anesthesia, we have to also adjust the position of the globe and all that. But the main point which I am stressing is that we must not put the eyelid onto the limbus, covering the limbus. Our position of final positioning of the eyelid should be always at the limbus or shade above the limbus if the levator action is poor. So this is a very important point which I am making, that we should plan for little overcorrection and should not go for undercorrection, because the levator action is usually poor in these cases. Now regarding the sling surgery, when you have a bilateral ptosis with poor LPS action, just like in blepharophimosis syndrome, etc., that will be very important to do a sling surgery, or the levator action is just 3-4 millimeters. You can do sling surgery, but bilaterality is a good thing. Once you have a bilateral ptosis, you can certainly plan a sling surgery. Regarding whether you want to have a facial lata or whether you want to have a facial lata or you want to have a silicone, it is up to, because both methods are good. As far as the material is concerned, both materials are good. So the important point in the sling surgery will be the position of the sling. The placement of the sling should be beneath the orbicularis oculus, in the loose areolar tissue plane, in that plane, so that the thread should not be visible through the skin. And then when you go to the superior transverse ligament of Whitnall, there you have to go a little deeper. And when you come out at the upper incision above the brow, you have to make good pockets on both sides and bury the knot very nicely. This burying of the knots is extremely important, because whatever we are saying that sling has failed and it has got infected and all that, That is not because whether you have used facial latta or a silicone, it is because of the faulty burring of the knot. So the knot has to be nicely buried. And again, the position of the lid margin should be shade above the limbus, so that, you know, if you are just burying the knots at that time, you will find that suddenly the lid margin has gone to the limbus, and after later on it will go another 2 millimeters down in all sort of slings. So you have to plan your position of the lid margin in case of sling at least on the limbus and not below the limbus. I think this will be very important. At the same time, we must explain the lid lag, which is so very difficult when the patient is looking down, eating, reading book, etc. So all the time we are looking down. So that point has to be very nicely explained to the patient, that we are going to give you a good correction in the primary position, but once you are looking down, there will be certainly a very bad lid lag, which will happen when in looking down position. At the same time, we have to explain that there will be some amount of lag of thalamus, and we must check the bells, etc., so that we should not cause any functional problem, any corneal problem in any case of ptosis surgery. Regarding the Marcus gun phenomena, to abolish the complete Marcus gun phenomena, we have to expose the levator, excise the levator aponeurosis in toto, and then excise some portion of the muscle and cauterize it and let it go into the orbit so that it never comes back. And also generous excision at the horns should be there. Otherwise, you see the horns, the levator is attached to lateral horn, medial horn. So some fibers which are there, if you do not do the generous excision at the horns, then some flicker movements will be continued, even if you do the levator excision and later on followed by the sling. So these are some of the important points in case of Marcus gun phenomena. There are individual choices of surgery, whether you want to do unit surgery, bilateral surgery, whether you want to do a bilateral sling without doing excision on the other side. So we have to nicely explain to the patient, take the photographs, explain to the patient, so that later on, once you do the surgery, there should be no problem, medico-legal problems, because ptosis is one area in which there is nothing like 100%. The lid lag will be there, lag of thalamus will be there, because the God has given you a poor LPS. Once the LPS action is poor, you are a gone case. You can't do anything much. Our idea is to give a good look in the primary position, minimum lid lag, minimum lag of thalamus, minimum functional problems, minimum corneal problems. I think that is what I want to give you the tips of my pulse of ptosis surgery. Thank you very much.
Thank you, sir. It is once again a privilege to have all the benefit of your experience from my teacher. Thank you again. And with that, I think we have finished our time. We would like to thank Bombay Ophthalmic Association. Dr. Lahane, thank you. We have enjoyed the session. Nice
Thank you. Yes, I enjoyed the session. Thank you, Bhattaria sir. Thank you, Gaurav sir. Thank you very much. All the speakers, I enjoyed the session. Thank you very much. Thank you for coming, sir. Thank you.
Last time it was in Ambezogai with Dr. Wangikar Sahib.
Yes.
Registrar or you were a lecturer that time, maybe.
Yes, sir. Yes, sir.
Very well to you, Dr. Lana. Great pleasure.
Yes, sir. Thank you, sir. Thank you very much, Bhattaria sir.
Thank you, Sumit. Thank you, Akshay. Thank you, Santosh and Ragini. Hand over to Akshay and Sumit for the final word, and then we hand over to the next session.
Yeah, I think I just need to thank everybody for taking their time out on a Sunday, and Dr. Lahane sir, Dr. Sumit, Dr. Ragini, and Dr. Santosh Honawar for curating such a wonderful program. And I think I'll be stuck to my screen the whole day because there's so many interesting talks in the oculoplastic session. So I think we can give the hall to the next session. Thank you everybody for your time and for your sharing.